Good afternoon and welcome. Thank you all for joining Johns Hopkins Government Community Affairs Showcase Series conversation. The Showcase Series highlights different programs from across the Johns Hopkins institutions that may be unfamiliar to many Marylanders. The series is also a forum to discuss the relationship the highlighted program has with the state of Maryland. My name is Senator Shelley Heddleman, and I represent District 11 in Baltimore County. I will moderate today's discussion. Today, we will be learning about the work of Johns Hopkins Opioid Stewardship Clinical Community from Dr. Suzanne Nesbit, a clinical specialist pharmacist in pain and palliative care, and she co-chairs the Opioid Stewardship Clinical Community, and Dr. Meghan Swarthout, Division Director of Ambulatory and Care Transitions Pharmacy Services, who also co-chairs the Community Engagement and Public Policy Work Group of the OSCC. Doctors Nesbit and Swarthout will be discussing two projects led by the Opioid Stewardship Clinical Community, the Overdose Response Program and the National Drug Takeback Day. Neither program would be possible without strong support from the state of Maryland. Before we get into the discussion, I want to go over some logistics. This webinar will be recorded and will be posted to the GCA and Hopkins at Home websites. Additionally, the questions and answers function has been enabled during this webinar. Feel free to type questions there, and we'll do our best to respond to as many questions as we can during the time available. With that, I'll ask Drs. Nesbit and Swarthout to tell us more about the Opioid Stewardship Clinical Community.
Thank you, Senator. Hello, everyone. Good afternoon. Meghan and I are very excited to share some of our initiatives with you and further discuss how we can improve the lives of Marylanders. I'd like to start by, over the next few minutes, telling you about two initiatives in particular through our opiate stewardship efforts. To begin with, it might be helpful to explain the structure of our opiate stewardship clinical community. Within the Johns Hopkins Health System, we use clinical communities as our quality improvement framework. And in 2018, the health system created the Opiate Stewardship Clinical Community. Myself and Dr. Steve Levin from Howard County, who is an anesthesiologist and pain provider, co-chair the clinical community, and our executive champion is Dr. Peter Hill, our Senior Vice President of Medical Affairs. You can see here we have 5 work groups within the clinical community, which each have leads. 2 of our groups are focused on education, both patient-forward, patient-facing education, as well as our clinicians. It's also important, we felt, to have an analytics team so we understand our baseline within the health system on several opiate stewardship metrics, and then also be able to monitor, engage what effect our initiatives are having. Our more recent work group has been addiction medicine, which we felt was really essential as the opioid crisis continues to unfold, and we are seeing more and more patients with substance use disorder and opioid use disorder. And last but certainly not least is our public policy and community engagement work group, which the initiatives that we're going to focus on today are really led by Meghan and her team on this work group to really bring these initiatives to life and, again, affect and really offer betterment for our colleagues and our Marylanders and our fellow folks. Sorry. Okay, I want to move on. I'm going to focus on some of our initiatives before I turn it over to Meghan. Early on, one of the things that we recognized within the clinical community is we really needed to focus on our naloxone co-prescribing and how we could also encourage and promote more naloxone availability within the community. So one option we have in our electronic medical record is something called a best practice alert. And by using this functionality and accompanying criteria, we were able to alert our prescribers when patients met criteria deemed to be at high risk for a potential opiate overdose. And then it would, as you can see in the red box, it would encourage and really educate our providers and prescribers on co-prescribing naloxone. And this would occur and fire within either an ambulatory encounter or at the point of discharge. And you can see some of the criteria that patients must meet for this alert to fire. We also tried to make it very easy for our providers that they just need to click within that red box and be able to order the naloxone quickly. And we also offered education in the form of FAQs related to naloxone and a link to the CDC guidelines. You can see on the side of the slide that when we started this program in early 2018, our co-prescribing rate was pretty dismal at less than 10%. As of August this summer, our co-prescribing rate just within Johns Hopkins Hospital, this isn't even the entire health system, is really approximately 60%. So this is really fantastic that we've really had such buy-in and able to really increase the prescribing of naloxone to our patients. Now that was one component of our naloxone initiatives. And we also were very concerned about our patients that are seen within our emergency departments and how could we actually get naloxone or Narcan spray product in their hands versus just a prescription. So we were already providing prescriptions, but that doesn't necessarily mean, as we'll see later, that the patient or caregivers are actually filling the prescription. We also were learning that throughout the pandemic, many of not only the state health department, but also the county and city health departments were really challenged during the lockdown in particular, but to get it out into the community and be able to distribute naloxone as they had been before the pandemic. So looking at that and other ways in which we could aid in the distribution of naloxone, we looked to the Maryland Department of Health Overdose Response Program. And we engaged with them on the Johns Hopkins hospitals, and eventually we actually discussed and became, as a health system, a registered ORP. This was rather unique, and we were the first ones in the state. And our goal was to be able to procure product, the naloxone product from the state, and be able to give it directly to our patients in our emergency departments, and particularly those that, again, were at high risk for an opiate overdose. And the registration really covers all of our Maryland-based hospitals and emergency departments. And we signed on with the ORP in the state in October of 2020, and were able to launch the program in earlier this year. So this is our phase approach to this implementation. We're happy to report phase one is complete. So we're dispensing naloxone at no cost to our patients in our emergency departments. Initially, it was our academic division, which is our Bayview campus, as well as East Baltimore Johns Hopkins Hospital. But our community divisions, Howard County General Hospital and Suburban, actually went live this summer in August. So we'll share some data with you on the next slide. So we're very happy that this initiative is up and running, and we're distributing naloxone and have a great partnership with the state. We're now entering our phase two of this initiative, which is providing training and dispensing naloxone at no cost to employees, staff, clinicians within the health system. And perhaps during the discussion, we can talk a little bit about maybe why that's needed and some particular concerns or discussions around that. But our first focus is on our security personnel, our corporate security personnel, and distributing naloxone and training on how each of them could respond to an overdose, either at their posts outside of the hospital or inside the medical campus as well. So this is underway. We have a great partnership with our colleagues in corporate security, and they are excited about moving this forward. So what is our impact thus far with this program since starting in January of this year? This is some data from our recent pool of data that we regularly send to the state. And 63% of the Narcan product that we're dispensing is occurring in the evening and night shift. We were particularly pleased to see this because many pharmacies are not open 24 hours and our own outpatient pharmacies are not available on our campus, are not available 24 hours. So it's really important in those evening and nighttime hours to make sure a patient or caregiver leaves the emergency department with the naloxone product in hand. Yeah. And recent literature that was published this year showed that if a patient left the emergency department with just a prescription for naloxone, that only 1% of them will actually ever get it filled at a pharmacy within 30 days of that emergency department visit. So it's really crucial that we are able to actually give them product so that we know they have it in hand. They also are given a prescription that they can then fill for subsequent doses. So we actually do both. They'll have a paper prescription and product in hand. So those are our initiatives surrounding naloxone. We have other initiatives surrounding medication disposal. So I will turn it over to Meghan for that portion.
Thanks so much, Suzanne. I'm going to transition to talking about our medication disposal program. This was one of our first initiatives in the public policy and community engagement work group, and wanted to give you a little bit of information of why are we focused on disposal. Well, if many of you think of your own medicine cabinets, there are probably some expired medications in those cabinets. In some cases, those might be less dangerous, and in some cases, they might be very dangerous. We know that historic prescribing practices are that prescribers might have prescribed a larger quantity of opioids, and that many folks who ultimately suffer from substance use disorder started with using an opioid that might not have been prescribed to them, but available in a friend or a family member's medicine cabinet. And so we really wanted to start with that low-hanging fruit of helping to get that unwanted expired medication out of the medicine cabinet. We also want to do this in an environmentally friendly way. So disposing of those medications down the toilet is a good way to make sure that no one can use them. However, not all water treatment plants are able to effectively filter out those medications. And we do know of reports that those medications can end up in the waterways and in our fish and in overall aquatic life population. So we wanted to provide both a patient safety element of getting medications that are unwanted and unused and expired out of patients' homes, as well as protect our environment. And we had data done here at Hopkins and published in 2017 that showed that patients who received an opioid after surgery 85% of the time did not dispose of opioids that they had left over following that surgery. So this was a huge need that we could see from our research. We also got confirmation from our PFAC, which is our Patient Family Advisory Council, that our patients said, yes, this is a need. We believe that the community would get behind this, and we really want to focus on this. So we want to listen to our patients in our community and build services based on what they were telling us the needs were. If we go to the next slide, This started with a partnership at the federal level with our Drug Enforcement Administration. The DEA has National Prescription Drug Takeback Day events. These occur every April and October, so 2 times per year. And what we learned starting in Baltimore City was that the only National Prescription Drug Takeback Day events were at police stations. And we wanted to create alternative options for patients who wanted to come to a location maybe they were already visiting, was close to their home, and a non-law enforcement option to dispose of your medications. So we started in 2019 at our Johns Hopkins Hospital at our outpatient center, and we have now grown to 7 locations. And we actually have our event this Saturday, October 23rd. So we wanted to time this showcase series to also put a plug in. Please, if you have unwanted expired medications in your medicine cabinet, we will have 7 locations across Maryland this Saturday from 10 a.m. to 2 p.m. where you can drop those off. We were just talking with Senator Hedelman that one of the new locations we are launching this fall is Green Springs Station in her district. And we make it really convenient. You don't even have to get out of your car. You just pull up, drop off your medications. We'll take them in a socially distanced way. All of our team will be in PPE, and we will make sure that those are safely disposed of. So more information is available and happy to share about our other locations for folks that are interested today. We can go to the next slide, Suzanne. We also have drug take-back bins. So we have bins in all of our Johns Hopkins outpatient pharmacies. There are 7 locations across our health system. And these bins, they look a little bit like a very secure mailbox, and you can drop your medications off in those anytime the pharmacy is open. We accept all kinds of different formulations and medications. These comply with all of the DEA requirements. Again, these are disposed of in an environmentally friendly way. And it's a pretty low cost to maintain. There's no cost to the patient to participate in this. But this is another way we wanted to have multiple factorial ways that folks could dispose of their medications. So this is available year round in addition to our drug take back day events. And our results are on the next slide. And so far, we've collected over 3,700 pounds of unwanted medications. You can see on this graph that our numbers continue to grow. We don't yet have our 2021 numbers in from our disposal bins, but those tend to be around 700 pounds a year. So if we add that in, I think we're quickly going to be over 2 tons, especially with the event on Saturday. Our drug take-back days also continue to increase significantly in the amount of medications they're collecting. With this April's event, a single event, breaking all of our records of collecting 990 pounds. So just shy of the 1,000 pound mark in one day. But we're excited to be able to offer this. And we continue to hear stories from patients that they were concerned of how to dispose of these, or they had very expired medications. We always have a little bit of a contest of what's the oldest medication we collect on Drug Take Back Day. And I think right now we're in the late 1990s. I think 1998 or 1997 was the oldest expiration date we've so far collected. So happy to get those out of medicine cabinets to be sure. And with that, I think we will turn it over for any questions and start our panel discussion.
Thank you very much, Drs. Nesbit and Swarthout. A couple of questions that we'll start with before we get to any listeners' questions. Can you talk a little bit about how your program has impacted the state of Maryland?
Thank you, Senator. I think I'll try to lead off with that one. I think the 2 initiatives we just highlighted are a great example of how we're really trying to make a difference within the state and in our community in getting naloxone product out into the community, into the hands of our patients, and subsequently our staff, caregivers as well. So I think our partnership with the state Department of Health has really been terrific, and other health systems. We were able to present at one of their recent meetings, and other health systems are also looking at this as a way to distribute naloxone. So we're really thrilled with that partnership. And then, as Meghan just outlined, trying to get unwanted medications, which, prescription opiates, really kind of kicked off the opioid crisis. And now we hear a lot about the synthetic fentanyl, which is really taking over. But prescription opiates are still in the mix of patients and families really having medications around. And this is where someone may first have an experience with an opiate. So it's still really essential to take those unwanted and unused opiates and any medication for that matter, and really dispose of it safely. And we're also trying to listen to our members of PFAC that Megan mentioned, our patient and family councils, to really see how else we can be partnering in the community and really offer other support within the community. And I think on kind of the flip side, looking at our prescribers and how we are internally managing our patients and thinking about how we're using opiates, how much we're prescribing at the point of discharge. Are we educating our patients on the naloxone we're dispensing to them? Are we giving them a safe amount, the lowest possible amount of opiates? So we're trying to kind of be good stewards within our own health system, and then reach out within the community as well.
Thank you. Can you talk a little bit about how the program adapted during COVID? I know these have been many challenging months. And paired with that, can you look ahead a little bit and talk a little bit about how you'd like the program to grow over the next couple of years?
Yeah, absolutely. Well, our April 2020 Takeback Day event was canceled. It was canceled nationally. So at that point in time, when we were all kind of working through the beginning parts of COVID, we had to temporarily stop. But we worked very closely with our hospital epidemiology and infection control team to get right back in October and do so in a safe way. And I think it was really interesting that after patients spent a lot of time in their homes, we had one of our largest events yet. So people spent that time cleaning out the medicine cabinet. We were glad to get started. As Suzanne mentioned, actually our overdose response program came out as a direct result of the pandemic. So we hadn't previously pursued becoming an overdose response program. There are a lot of great overdose response programs that are run by nonprofits in the city and in the counties in Maryland with support from the local health departments. And what we were hearing was that those programs were not able to operate as they normally did. We were continuing to see the statistics come in from the state and from the county health departments with opioid overdose deaths on the rise. And we felt that we needed to take a partnership in being able to respond to that. Our emergency department was open. We were seeing patients with either active overdose or an active diagnosis of substance use disorder in our emergency departments. And so that was the point where we really started working with the state and having a discussion to say, could we become an overdose response program? And the Department of Health was a wonderful partner. They saw the need, and really the overdose response program was a direct result of that. I think in terms of where we're headed, you heard Suzanne talk about it. We want to work with our employees and our security personnel to really expand access. We want, if all of our employees want to have it on them, whether they interact with friends or family members, or they are just out in the community and they would encounter someone who's having an active overdose, be equipped with the medication to be able to intervene and then call for emergency personnel support to help that individual. So we have a lot of employees across the health system, and equipping them all with naloxone is just one more way to make our community safer. We also then want to look to work with community partners, some of whom we already work with, of how we can help them learn how to become an overdose response program and train them and increase our overall number of overdose response programs. And while we're doing that, offer our support at potentially ORP community events. And working with the state and the counties, we're looking at where our ORPs already covering? Where might we have zip codes or neighborhoods where there is a need and we don't have overdose response program support in there yet? And how could we either temporarily fill that and then work with a community partner to become an ORP? Some of that we've seen recently while we've been out in the mobile vans with our COVID-19 vaccine efforts in our community. We've been bringing naloxone with us there as well, identifying community partners, and want to build on that. So hoping to both vaccinate patients and dispense naloxone, two life-saving initiatives at the same time during the pandemic.
That's terrific. And actually, it's a good segue into the next question. Since you've already touched on the community response and organizations that you partner with, can you talk a little bit about who those organizations are and how the community has responded when they've gotten those prescriptions? And can you talk a little bit about also what parts of the community are more difficult to reach?
Absolutely. So we partner a lot with the city of Baltimore as well as the county health department. So many of those, the city and Baltimore County both have mobile health clinic vans. So our partnership has started with those organizations. We also have some groups in Maryland that bring together through Hopkins and multiple nonprofits, just sharing of information of what nonprofits need, what we're hearing from the community. And we might be talking about food insecurity, but we're going to have a place where we're distributing meals. Can we also be distributing naloxone too? So those are the things we have on that phase 3. We showed you phase 1 and phase 2, but that's in phase 3. So I'm starting to really work with those organizations. Also through our patient family advisory councils, we have a lot of members of our faith-based communities and our churches. And we're really talking with those individuals. They help spread the word of our Takeback events. When it is allowed, we have volunteers from some of those community organizations also participate with us in our Takeback Day events and have seen a lot of success with that partnership. We also have some of our patients who actually serve on our opioid stewardship clinical community groups. So they're actively involved in our decision-making and in our meetings.
If I could add, thank you, Megan. Another area that we're really looking at increasing our ability to aid in the community is through our addiction medicine services. And we've really been looking the past year at what are our services across the health system, both on an inpatient basis and in an ambulatory basis. And this was another key area where the pandemic really highlighted the need for some, creative approaches, because a lot of the treatment centers, had to shut down face-to-face engagement, and entering patients really became really difficult. And so even during last spring, during the initial phases, we were working within the addiction medicine group of how we could provide patients with treatment until such time we could then transition them over to a community program. So we continue to look for ways, to partner with some of our skilled nursing facilities and rehabs that, patients who need to continue treatment or initiate treatment, but then need a skilled facility, and how can we partner with them to maintain their treatment for their opioid use disorder while they're getting, while they're in those facilities getting perhaps IV antibiotics, et cetera, and then have a transition to the community. So that's another focus for the future is that partnership and that transition of care.
Thank you. A couple of viewers have asked how they can learn more about being active in their community, and then how can they support organizations that you are partnering with?
I'll take a step, and then Megan, feel free to join in. So that's a great question, and really appreciate the enthusiasm. I think one place to start in your community is to reach out to the health department and really think about, engage them in what programs they have, where do they need help, A lot of the overdose response programs throughout the health department, you don't necessarily have to have any type of, you don't have to be a pharmacist or nurse or a physician. You don't really need any medical training. They'll train you and then you can participate as well. There's also other risk mitigation strategies that the counties and city are employing. And then I think the other one is within faith communities and maybe what partnership that they have within the communities or what programs that they're trying to initiate or partner with in terms of again, not only naloxone, but getting the word out about treatment for opioid use disorder and where there's available treatment. Those are some of my initial thoughts.
Yeah, I agree completely, Suzanne. In addition to your local health department, the Maryland Department of Health also lists all of their registered overdose response programs. So you can find what are the overdose response programs in your area. I would say the first step is if you don't carry naloxone on your person, get trained, know how to use naloxone, carry it on your person so that you can be that good Samaritan or that responder. There are laws in place that provide protection for anyone who uses naloxone and responds in an emergency, so that there is not kind of a liability concern there. And then, as Suzanne noted, in addition to being trained to how to use it personally, you can also be trained of how to be a naloxone trainer. And as Suzanne noted, no medical degree required for that. Their overdose response programs will train you to be that. And I think a lot of the overdose response programs rely on volunteers to help with what they call pop-up events. So in certain neighborhoods, whether they be on weekends or weekdays, there's usually a lot of different opportunities. So connecting with your local overdose response program. And as Suzanne noted as well, these groups tend not to have as many volunteers, but helping to support 12-step programs, making sure that there are 12-step programs in your area or other type programs that are really there to create a community and support people who are working through substance use disorder. The overdose response programs also tend to have a lot of good information of just how to interact with and support someone who might currently be using drugs, and kind of meeting them where they are, and trying to support them in a non-judgmental way and be ready to help support them with resources at the point that they would want to seek treatment.
That goes perfectly into one of the next questions, which is there's a lot of discussion around opioid abuse comes with a lot of social stigma, even when you're talking about recovery and solutions to the problem. Are there methods that you have found successful in opening up the conversation with someone that you suspect is struggling with the issue?
Yeah, that's an excellent question. I think to start, we have to educate ourselves. Not only am I talking about healthcare professionals, which are important, but I think throughout the community, we really need to educate ourselves on using language that is not judgmental, non-stigmatizing, and phrases and terms that, we've heard for a long time, but are really not going to further our discussion. So we're also looking at how we educate not only our current staff, but being, university-based, academic-based, how are we training our students so that they kind of know to use non-stigmatizing language. And then, as you said, how to start those conversations. And then we're going so far as we're going to be launching soon a campaign that is an anti-stigma campaign where all of our clinicians and staff within the health system will actually sign a pledge that words matter. And there's education on non-stigmatizing words, phrases, and just kind of really think about it and make a pledge that you will do your best. So that's one way we can help internally. And so I think starting those conversations then really leads to, addiction is a disease, and you need to really approach folks like you would any other chronic disease. And really, I think Megan and I would both tell you that just really interacting with patients and asking them, how they're doing, what's going on with them, where are they in their thinking about treatment? Are they ready? What is perhaps a barrier? Several times it's just basic things like food and shelter. A patient I just saw this morning, a lovely gentleman, and really said, yes, I want to continue with my buprenorphine, but I'm really nervous when I get discharged because currently I'm homeless. So often we have to meet them with their basic needs and all the while be talking with them about their readiness to start their journey on treatment and recovery.
Thank you. Someone who is participating today said that they have seen some ads about buprenorphine. Are you behind those?
Some ads. Oh, I haven't seen ads. Have you, Ethan?
Let me share the control list.
Maybe Suzanne, perhaps just, and I know you use this, maybe talk about how the substance use kind of disorder treatments available and how the addiction medicine team approaches those. We certainly, see them as a viable treatment option for patients, and you're certainly a better expert than I am, Suzanne, in that area. Now, in terms of Hopkins addiction medicine ads that include buprenorphine, it's possible. We're a big organization, and we do use them. But the opioid stewardship clinical community did not specifically promote those.
No.
Thank you. Thank you. So someone is asking, do you have resources for education that you recommend? I'm guessing that is going towards the how we talk about in a non-stigmatizing way, how we would approach and talk with others in the community about that. And then do you partner with any programs that focus on the mental health portion of opioid use?
Well, I mean, it's certainly the mental health aspect is key. And so really our teams here within Hopkins really need to encompass both kind of the clinical management, and that's, starting treatment with either methadone or buprenorphine products such as Suboxone. So that really is a team effort. The other really key component to that treatment is a peer recovery coach. And we have peer recovery coaches inpatient and in our EDs. And these are persons with the lived experience, and they're really invaluable to talk to patients, really start that conversation about their readiness, again, challenges that they're facing, and what may work best for them. Even discussing the options between buprenorphine versus methadone in someone who may have already had both of those experiences is really invaluable. In terms of language and trying to educate ourselves, the NIH has several documents and websites you can look at. Some of the, as well as NIH, SAMHSA, which is and I always get the whole name wrong, but it's the addiction medicine arm of the federal government and NIH, but they have educational material related to just addiction in general, but also non-stigmatizing language. And the only other one I wanted to mention is some organizations like Shatterproof will also that are kind of more grassroots advocacy and patient focused, and often started by family members who have lost loved ones to an overdose, such as Shatterproof is. They also have education and materials about language and treatment options.
Thank you. Can you help us with what the right terminology is now for someone with substance use disorder without being so stilted that the stigma comes through?
So what I typically use is people or persons who use drugs. So just kind of if they're actively using drugs. And I believe in terms of, and Suzanne, correct me if I'm wrong, for a patient who is actively seeking treatment and looking at this as a chronic disease, just like we would look at as high blood pressure or diabetes or high cholesterol, it's typically substance use disorder or opioid use disorder.
Great.
You've got.
Thank you. I wonder if you could talk a little bit about what state policies and resources would make your work more successful. Obviously, as a state legislator, this is something that we work on all the time, even while we're in session. Certainly, there are a lot of bills focused on the issue, but even out of session, in interacting with our constituents and the community. Can you talk a little bit about what state policies could make your work a little easier and more comprehensive?
Yeah, absolutely. One that has actually come up recently, and we're going to be hopefully talking more with the State Insurance Commission, is that unfortunately, if a person goes to an outpatient pharmacy right now, there's a standing order for naloxone. So anyone can get naloxone. You can walk up to any outpatient pharmacy and you can ask for it. You don't necessarily have to go through an overdose response program. When that happens, in some cases, the medication will then end up on your personal active medication profile, because the pharmacy needs some way to dispense it and they put your name on it and it ends up on your profile. Unfortunately, we know of cases where that is then being used to penalize someone from a life insurance policy perspective or other information where they might need it from themselves. They might be doing it to carry it as a good Samaritan, but really creating some anonymity or privacy that information cannot be used if you would get it from an outpatient pharmacy for those purposes. And so one of the reasons we're exploring being able to provide it through the ORP for our employees is because some of our employees have indicated that they've experienced this or experienced barriers. Some of the naloxone products are affordable, some of them can be more expensive, and so there can be barriers depending on your insurance copay for naloxone as well. So I think making sure that we create protections that folks that are seeking naloxone either for themselves or in order to be a good Samaritan aren't stigmatized from the perspective of having potential negative downstream ramifications related to any life insurance policies or other insurance policies that they may carry.
Great. That's a really important one. Someone wrote in, what else can we do in the healthcare system to prevent this issue before it happens?
Oh, that's a great question. And, hopefully we've conveyed today that we're both looking internally on how we as a health system can do better educating our current and future professionals, as well as outward facing and interacting with our community. So I think we're still continuing to think about what else besides opiates can we use to manage a patient's pain? What are all those components of pain? So we want to strike this balance of really managing someone's pain, but also realizing that there could be risks with that, particularly with opiates. And also really being able to assess our patients. Are they already at risk and maybe we don't know it? Are we really asking the right questions? So thinking about how we can approach our patients and treat them appropriately, educate them. Also, some patients have maybe expectations that we are able to alleviate all pain. Unfortunately, that's not true. But really educate ourselves and our patients within our care about what options are available, when are opiates appropriate, when have we met the limitations of opiates? And they're really perhaps not helping function and really attaining the goals we want for that patient. And we're also looking to our prescribers and really creating metrics within that analytics group that we're sharing with them what their prescribing patterns look like, what their average MMEs, morphine milligram equivalents, that comes right from the CDC guidelines. Where do they fall within those guidelines with like peers within their departments? What is their co-prescribing rate of naloxone? Are they X-waivered? That's another initiative, trying to get more of our providers, our prescribers, DEA X-waivered so they can prescribe buprenorphine products for the treatment of OUD. So many different initiatives where we're trying to educate ourselves, really think about how we best help patients and maintain this balance of pain management and really being mindful of risk with opiates, particularly in the long term.
Okay. One more question. Other than verbal stigmatization, are you considering other forms, such as words found in texts or journal articles? Have you focused on kind of the written word and changing perceptions there?
I would say absolutely. And Suzanne, correct me if I'm wrong. I think the written word will be part of the anti-stigma campaign, and really educating our own clinical teams and prescribers in what we're writing, as well as what we're saying. We've also seen it sometimes in policy, actually. So you're talking a little bit about policy, but looking at Medicare drug policy or Medicaid drug policy, we'll sometimes still see outdated terms and words used there. And working with our government affairs team, we try to bring those kindly to folks' attention to make sure that in our policy language, we're using the most up-to-date and anti-stigma terms as well.
Great. Well, we're getting towards the end of our time here. So I want to thank you, Drs. Nesbit and Swarthout, for your time this afternoon and for providing a really thorough and informative overview of the opioid stewardship clinical community. It's innovative and important work always, but especially as we see overdoses continue to rise. As a member of the Maryland General Assembly, I'm proud to have this institution and these programs available to all Marylanders. And I also appreciated learning about this unique part of Johns Hopkins enterprise. And I'm thankful for the investment that you all have made in allowing Maryland to lead in this field. I'd also like to thank those who tuned in to listen today to the conversation in the Showcase series. Johns Hopkins Government and Community Affairs team will host more of these events in the future, highlighting the anchor institution's relationship to Maryland. For questions, please email gca@jhu.edu. Thank you very much, everyone, and have a wonderful afternoon.